Hello, everyone, and thank you for joining today's webinar presented by the National Academy of Medicine Action Collaborative on Clinician Well-Being and Resilience. My name is Charlie Alexander, and I direct the initiative. Today, I am joined by my colleagues, Neil Busis, member of the Wellness Task Force at the American Academy of Neurology, Robert Harbaugh, past president of the Society of Neurological Surgeons, Arthur Hengerer, past chair of the Federation of State Medical Boards, and Daisy Smith, vice president of clinical programs at the American College of Physicians. This afternoon, we will provide an overview of the Action Collaborative, discuss several resources that have been developed by our working groups, and respond to your questions. We're expecting nearly 1,000 people to join us from all over the world, from the United States, Canada, Lebanon, the Netherlands, Australia, Argentina, Chile, Indonesia, and several additional countries. We look forward to our time together. This webinar is being recorded and will be available on our website next week, along with the full PowerPoint presentation. Please feel free to submit your questions throughout the webinar. We will address them at the end of the presentation. Please submit your questions in the following format. Address the question to one of the working groups or the collaborative overall, and include a succinct question. Please make it a true question rather than a comment. Due to the number of people on the webinar, we will not be able to answer all of the questions we receive. However, we will have a full record of the questions and will share them with our working groups. We encourage you to join the conversation online during this webinar by tweeting at the NA Medicine using the hashtag ClinicianWellBeing. Clinician well-being is essential for safe, high-quality patient care. Yet clinicians of all kinds, across all specialties and care settings, are experiencing alarming rates of burnout, depression, and suicide. Burnout is a syndrome characterized by a high degree of emotional exhaustion and depersonalization, and a low sense of personal accomplishment at work. You can see here some of the more telling statistics from the literature. 400 physicians commit suicide each year, a rate more than 2 times that of the general population. Physician rates of depression remain alarmingly high at 39%. There is a 23 to 31% prevalence of emotional exhaustion among primary care nurses, and 24% of intensive care unit nurses tested positive for symptoms of post-traumatic stress disorder. The Action Collaborative on Clinician Well-Being and Resilience, launched in January 2017 as an effort to convene the many organizations working to address these issues separately, to move towards collective action and targeted investment to achieve together what we cannot achieve individually. The initiative has 3 key goals. The first is to raise visibility of clinician burnout, depression, stress, and suicide. The second is to improve baseline understanding of challenges to clinician well-being, and to advance evidence-based, multidisciplinary solutions, leading to improvements in patient care by caring for the caregiver. Efforts are needed at all levels, individual, organizational, and systems level, but especially at the systems level. The collaborative is looking beyond individual resilience and focuses primarily on promoting organizational, system, and culture change. The collaborative is chaired by Victor Zhao, President of the National Academy of Medicine, and is co-chaired by Daryl Kirch, President and CEO of the Association of American Medical Colleges, and Thomas Naska, CEO of the Accreditation Council for Graduate Medical Education and ACGME International. A high-level steering committee provides support and strategic direction to ensure the collaborative achieves its goals. The steering committee includes the chair, co-chairs, and co-leads of the working groups. The collaborative is comprised of about 60 participants representing medicine, nursing, pharmacy, dentistry, professional societies and membership organizations, government agencies, health information technology vendors, large healthcare centers, public and private payers, researchers, trainees, early career professionals, and patient and consumer perspectives. The full roster is available on our website. We are fortunate to have 37 committed, active, and engaged organizations providing financial support for the collaborative. The initiative is organized into 5 working groups. The first is research, data, and metrics. The second focuses on a conceptual model for this work. The third looks at external factors and workflow. The fourth is our messaging and communications working group. And our newest group, publications and art show. In a moment, you'll hear from the co-leads of these working groups about their progress to date and what's on the horizon. On January 25th, the New England Journal of Medicine published a piece authored by Drs. Zhao, Kirch, and Nasca. The commentary, entitled "To Care is Human, Collectively Confronting the Clinician Burnout Crisis," emphasized the need for urgent, collective action and targeted investment, and described how the collaborative is advancing the movement to improve clinician well-being. In addition to synthesizing research, authoring discussion papers, developing tools and other resources, and convening diverse groups of stakeholders, the collaborative is calling on artists of all skills and abilities to explore what clinician burnout, well-being, and resilience looks, feels, and sounds like. We hope the art show will promote greater awareness and understanding of barriers to clinician well-being and solutions that promise a brighter future. 3 artists will be invited to present their work during our May 2nd meeting. 30 pieces will be displayed during our in-person gallery on May 2nd, and 100 works will be featured in our permanent online digital gallery. We've received 125 submissions as of yesterday and are accepting submissions until February 16th, so there's still time to submit your masterpiece. Please save the date for our next in-public meeting taking place in Washington, D.C. on May 2nd. A registration link and additional information about the meeting will be communicated via listserv. To provide an opportunity for organizations to discuss and share plans of action to reverse clinician burnout and promote clinician well-being, the NAM is collecting statements describing organizational goals or commitments to action. So far, we've received 130 statements from a wide variety of organizations, and we are accepting statements on a rolling basis. We launched the collaborative in January 2017 as a 2-year activity. However, to capitalize on our momentum and public attention to this issue, we agreed to extend for an additional 2 years, for a total of 4 years. An important next step is the generation of an NAM consensus study on systems approaches to improve patient care by supporting clinician well-being. The study has the potential to drive transformative change in the area of clinician well-being, similar to how the Institute of Medicine reports to Err is Human and Crossing the Quality Chasm did for medical errors. We are currently fundraising for the study and hope to launch in the coming months. If your organization is interested in financially supporting the study, please send a note of interest to ClinicianWellBeing@nas.edu. Our vision for the future is that we, together, build a campaign of systems change to improve clinician well-being. This will be achieved through leveraging the work of the many organizations committed to improving the well-being of healthcare professionals, the forthcoming consensus study, and continuing to produce discussion papers and commentaries, tools, and other resources, hosting public meetings and webinars, and reinforcing the work of the many organizations that are in this space. We encourage you to participate in our activities and in each other's activities, and remain active partners in building a campaign around clinician well-being. To learn more about the initiative and to sign up for our listserv, please visit nam.edu/clinicianwellbeing. The resources that we discuss throughout the rest of this presentation are available on that site, along with our full working group rosters and our list of sponsoring organizations. I will now turn it over to my colleague, Robert Harbaugh, who is past president of the Society of Neurological Surgeons and co-lead of the Research, Data, and Metrics Working Group. Bob?
Okay, thanks, Charlie. Well, you know, our group has worked to identify valid and reliable instruments that we think will help people to measure burnout, well-being, depression, suicide risk. We profiled actually quite a large number of instruments to assess these areas and came up with what we thought were the most valid, reliable, and applicable instruments. And these include things like the Human Services Survey for Medical Personnel, Oldenburg Inventory, the Mini-Z, Copenhagen Burnout Inventory, Well-Being Index, Patient Health Questionnaire, and these are available on our website, along with some introductory text, a list of frequently asked questions, and then a survey for visitors that we would like them to suggest what other instruments they might find useful. We're also working on a paper recommending which measurement instruments to use in which context. And the idea of this is to help to try to improve the research that's being done. We're not conducting independent research, but we want to make it easy for other people to do high-quality research. Toward that end, we also have an annotated bibliography of interventions to reduce burnout and improve well-being in physicians and nurses. While we were discussing how we were going to go about this, we found out about the work of another organization, the Collaborative for Healing and Renewal in Medicine, or CHARM. And CHARM had created an annotated bibliography of interventions by looking at recent systematic reviews for both practicing physicians and physicians in training, and this seemed to be really high quality work, and we've invited them to join our group so that we don't, reinvent the wheel and we get the most efficiency out of this. Right now, to complement the work that CHARM has done, our group is going to try to do the same kind of annotated bibliography for nurses that has already been done for physicians and physicians in training. And then we hope to combine the National Academy of Medicine and the CHARM bibliographies into a resource to be available on the website. And I think that's going to be of significant value. We're also looking to see if there's any other work that's being done for other non-physician, non-nurse healthcare providers, but don't know of any at present. Our next steps are to, one, try to develop some metrics to assess the impact that the Action Collaborative is having. And so that's, website hits, how many times our bibliography is cited, et cetera, et cetera. We're also looking to draft a discussion paper on clinician wellness, which is a broader focus than any of the previous ones. And we wanted to draft a paper on the financial cost of nurse burnout. We had initially discussed an article on the cost of physician burnout, but Dr. Shanafelt beat us to the punch and published a very good one on that topic, so we're going to try and focus on nurse burnout. So I think our group is working well. We've accomplished a lot in the first year, and we look forward to continuing our efforts in the future. Charlie, back to you.
Thank you, Bob. I will now turn it over to Art Hengerer, who is past chair of the Federation of State Medical Boards and co-lead of the Conceptual Model Working Group. Art?
Thank you, Ms. Alexander, and want to just acknowledge my co-lead on this project, who's Dr. Lois Nora, and also the group that's worked very hard on designing and developing this conceptual model, which we'll share with you in a minute, and also comment on the discussion paper that explains this and a list of terms and definitions that we've come up with of all the different things that you'll be seeing in the conceptual model. So if we could put up the slide showing the initial conceptual model design. Some of you will look at this and think that it's similar to everything you've seen before and a number of models that have been put forth, or you think it's looking at what seat you're going to select at a theater. But in fact, this is going to be significantly different as you listen to what I talk about here, in that this is going to be a very dynamic model, and the importance of this model is going to show that it covers all points of careers. It covers all the different healthcare providers and will become very interactive. So as we look at the model, we'll start at the center, and a lot of time was spent in the discussion and creating of this, and ultimately it was decided that the patient and their well-being would be at the center of this nucleus, surrounded initially by the clinician-patient relationship and then the clinician well-being to see that that relationship functioned effectively. And then you see the circling arrows, which shows that all of these different phases and parts of these factors are interactive. We see that the yellow, which if we go to the next slide, covers all the external factors or system factors, which take up more prominence than the blue, which are the individual factors. And so after spending some time looking at literature and researching all the issues regarding resilience, well-being, and burnout, these were the 7 major factor areas and domains that came to the top. And so you see on the yellow, which are the external factors, we have social and cultural, we have the regulatory, business, and payer environment. We have organizational factors, and then we have learning and practice environment. We structured those in a way not necessarily of importance, although we felt that social and cultural factors kind of sat near the top. As we looked at the individual factors, we felt that the healthcare roles should sit beside those cultural factors, and at the bottom we thought that learning and practice environment should be fairly close to the skills and activities of the individual. And we rotated those slightly so that none of them sat right at the base of the structure of this. We then moved from setting up these 7 domains to looking at the various subheadings that fit under each one of these that you see on either side. And again, we developed those lists based on going to the literature and research that was available, and we put these in alphabetical order. That was done purposely so that we didn't select a prominence of what the committee felt was most important, because what will be most important is what the individual going to this model is looking at and looking for. Having completed this recently, we moved to develop a descriptive paper, and that is called A Journey to Construct an All-Encompassing Conceptual Model of Factors Affecting Clinical Well-Being and Resilience. And we discuss how we developed this in more detail than I've just explained for you, and where we see it going. We use some modeling of this in terms of taking different scenarios and running them through to see how it will work, because where we're going to go from here now is that this is the initial static phase of this model. But what we feel and what we're developing is this will be a dynamic model that people will be able to go online, They'll be able to use their cursor to move around to one of these specific types and drill down in. And as you're going to hear in a few minutes, a little bit about a knowledge hub that's being created that will be able to infiltrate into another layer below this. We're talking about developing stories and scenarios that may be lower down for people to understand. This model is also active. As things change in this whole field of understanding the wellness and resilience, we can alter the different lists within here, and this will allow for better understanding of what's happening. So although this looks like some models you've seen before, I think what you're going to find is it is much more dynamic, much more useful, and hopefully offer a great help to the clinicians, so and nurses and everybody else within the healthcare system that this will apply to. So I'll turn it back to you, Charlie.
Thank you, Art. I would like to introduce Daisy Smith, Vice President of Clinical Programs at the American College of Physicians and co-lead of the External Factors and Workflow Working Group. Daisy?
Thank you, Charlie, and thanks for the opportunity to present on this call. I'd like to thank my co-lead, Pam Cipriano, who this work is her work and the work of all the folks who have joined our working group. So I'm going to start with the fact that, as you saw, the conceptual model, external factors is a very broad category, and a lot of our work was figuring out how to narrow down that broad category to areas to focus on where we could really help move the needle. So I'm pleased to announce that the first discussion paper that came out of our working group was published at the end of January by the National Academies Press, and it's available via the link on this PowerPoint presentation, and it really focuses on clinical documentation and solutions to alleviate burnout. And the paper examines the evidence behind the link between clinical documentation requirements and clinician burnout, and highlights challenges and opportunities to improve the situation, and how we might be able to reimagine health IT and clinical documentation in a way that it could really support the work that's central to all of us. So that was the first product of our working group. We have another paper currently in a draft format, which is entitled Implementing Optimal Team-Based Care to Reduce Clinician Burnout. And this paper analyzes the evidence supporting the implementation of high-functioning teams to promote clinician well-being and reduce burnout, as well as to improve patient outcomes. And the paper focuses on evidence-based key features of high-functioning teams, but also is making recommendations for what type of changes, both in the regulatory and the reimbursement environment, that can be made to foster effective and efficient team-based care, since we think that this will really be impactful in improving clinician well-being. So you can see that, where we have identified two of the areas that were on the left side of the conceptual model, and built the evidence base linking these to the problem and potentially to the solution. So now what we want to do is really identify specific actions that the collaborative can take to build on the evidence base that we've outlined in these papers, and really focus on using the power of the collaborative to make recommendations that can have an impact and have a larger impact than we can have as individual clinicians or as even individual organizations. And to give you a specific example of that, based on our clinical documentation paper, we've started to convene thought leaders and influencers at CMS and ONC to address some of the regulatory burdens and barriers, as well as the reimbursement barriers that are driving the administrative burden associated with documentation. And we hope to do the same around the barriers to high-functioning teams as well. So in addition to taking on these two specific topics, and identifying and working to alleviate barriers to improving things in those areas, we also want to take this opportunity to be a bit more visionary and think about convening, and we're planning a convening in October of key influencers and stakeholders in the digital health field, and really brainstorming about how we can sort of reimagine the future of clinical care and really take the power of the digital health environment and use it to support clinicians, patients, and the clinician-patient relationship instead of having it be the other way. So we do want the work of our group to be a bit more visionary looking forward, and again, really focus on the things that we think the power of the collaborative will be able to change. So thank you for this opportunity. I'll turn it back to you, Charlie.
Thank you, Daisy. And finally, I would like to introduce Neil Busis, member of the Wellness Task Force at the American Academy of Neurology and co-lead of the Messaging and Communications Working Group. Neil?
Thank you, Charlie. I'd like to thank my co-lead, Cliff Knight, our working group members, and our excellent staff for their contributions to this project. Message testing was done in the fall of 2017. Over 800 people completed the survey. The purpose was to figure out the best ways to message about this topic. And this is what we've learned. Emphasize people over profits, focus on fixing the system, not blaming clinicians, keeping messages brief, use statistics and specifics, use images that convey that burnout is a serious problem, but at the same time frame the issue positively, promoting well-being versus combating burnout. The message testing will be used to develop a public messaging campaign in 2018 and to guide the work of the Action Collaborative and the development of our online Knowledge Hub. So if we could move to our second slide. The Knowledge Hub will be released to the public later this spring. It serves all three goals of the Action Collaborative: to improve baseline understanding of burnout, to raise the visibility of burnout, and to elevate solutions that will ultimately promote clinician well-being. Because the site is still under construction, the content that you will see on your screen during this preview, including graphics and photos, will not be considered final. We intend that the Knowledge Hub will be a one-stop shop for those wanting to learn more about clinician burnout and those looking for solutions to improve clinician well-being. The Knowledge Hub will help us all work together to learn from each other so that we can fix the root causes. The site will be developed in phases incorporating user feedback and other Action Collaborative products such as the Knowledge Hub as we refine it to make it even more helpful to our users. So let's visit the Knowledge Hub site. And here we are. This is the home page. The home page includes links to its 5 main sections in the upper right corner: About, Causes, Effects, Solutions, and the Resource Center. It will enable you to easily search for resources on clinician burnout and well-being in that big text box there. And then we'll scroll down a little bit, and you will see featured resources. These are intended to help you identify resources that have been most helpful to previous users, and they will be dynamically pulled in based on user feedback. And then right below that, you will see links to causes, effects, and solutions. They're below the featured resources, and this area serves as an additional navigation panel in case you missed the stuff up at the top on the right. And then boxes further down will display announcements about the work of the Action Collaborative and or recent publications of interest. Right now you can see it says attend a meeting and call for commitment statements. Let's move on to the featured graphics. The featured graphic will change from time to time and can be shared on social media. It will allow you to interact with the Knowledge Hub, share messages from the site, and drive new users to the Knowledge Hub. The site map is at the very bottom of the page. Extensive user testing guided the organization and navigational structure of the Knowledge Hub, and the site map has been streamlined to make navigation as straightforward as possible while at the same time covering all relevant topics. So let's dive in a little deeper into the site. We're going to go to the About page next. The About page that you're seeing is designed to orient users to the site and to provide background information on the Action Collaborative. The About page will feature resources and products from the Action Collaborative. Let's then move on to the Effects page. And we'll wait for them to get there. Basically, while we're waiting for the website to get there, as you notice when we talked about it originally, there's About, Causes, Effects, Solutions, and the Resource Center. So the Effects page, which you're seeing now, is one of those 5 top-level topics. And the idea is that you can click through these topics to learn more about the subjects. And then we're going to move to an Organizational Strategies page, which is a subtopic page. You can see that on this screen, and the operators will click on that, and that will come up shortly. So here it is. So this is an example of a subtopic page. Each subtopic page will provide a summary of the topic with links to helpful resources and research. The featured resource will be content that the Action Collaborative deems most helpful for that topic, such as a landmark study or specialized toolkit. And then below that, there will be 3 additional resources that will be dynamically pulled in based on user ratings. For example, if you're looking for information about how clinician burnout results in increased turnover, when you first come to the page, the resources immediately available to you will be those that others found most helpful regarding that topic. And then finally, we'll visit the Resource Center page. This really lies at the heart of our searchable database for resources currently available about clinician burnout and well-being. You can search the database by keywords, or, as you can see on those left-handed side, filter by topic area using the topics on the site map, the year published, the type of resource, such as a blog, original research, art, and the audience type, such as physician, nurse, dental, or pharmacy healthcare provider. Our goal is to make it easy for you to find the resources that are most relevant to your needs. You will be able to rate the helpfulness of resources, which will then feed into the other pages, as I've mentioned earlier. If users frequently designate a resource as helpful, it will appear further up in the search results, and you will be able to submit resources not currently included in the database. So our next steps are to finalize the design of the site. It will no longer be in Latin in parts of it. Develop a strategic plan to launch the Knowledge Hub and further highlight the work of the Action Collaborative, and develop a 2018 messaging campaign. So that's a visit of the site in progress, and we'll go back to the slides and to Charlie. Thank you.
Thank you, Neil. We will now open it up for questions. Thank you to those of you who have already submitted questions. If you have yet to do so, please remember to use the following format. So I'll start with a couple that have come in since we've been on the webinar. I'll address a couple of general questions, but to prepare my colleagues, Bob, your first question is, how did you determine which instruments to profile in the list of validated instruments? So if you could think you could think on that for one, and then I'll read all the other questions. So if you could think on that for just 1 minute.
Oh, okay.
Art, your first question is, what is the time frame for this conceptual model being released for interactive use? It's very useful here for our curriculum with students. Daisy, your question is, will you be addressing the legal and scope of practice issues that impede team-based documentation? And Neil, your question is, how does the Action Collaborative plan to include the public in their overall messaging and communications efforts? So I will briefly address some general comments that we've received, and I'll turn it over to Bob. So the first general question we received is, how can one get more involved with the Action Collaborative? So we love this question, and we would encourage you to sign up for our listserv to learn more about our updates, upcoming meetings, to participate in requests for information, and to register for our events. We also encourage any and all organizations to submit an organizational commitment statement and join our network. And then also we have several resources that we will produce throughout our 4 years together that will be reviewed by external folks. So if you want to join our data bank of reviewers, please also send a note to ClinicianWellBeing at nas.edu. The second general question we received is, when will we be notified if our commitment statement was accepted? So your statement should appear on the website. If it has not appeared, please send a note to ClinicianWellBeing at nas.edu, and we'll get it uploaded as soon as we can. Finally, is there a link to the survey instruments available online? And the answer is yes. So there is a link in the PowerPoint. It is also, the survey tools are also available on our website at nam.edu/ClinicianWellBeing. So those are live right now. So now I will turn it over to Bob to talk about how we determined which instruments were included in our profile.
Okay, thanks, Charlie. The Steve Bird, who's the other co-chair of this research data and metrics work group from the Society of Academic Emergency Medicine, and I, we're very lucky to have members of this group who are real experts in the field of clinician burnout and resilience. People like Lottie Derby, for instance, at Mayo. So the group looked at a number of instruments that were out there to measure various aspects of physician burnout, depression, et cetera. And we chose what we thought were the most high validity and most reliable instruments to use in a variety of settings. And we also wanted to make sure that we chose instruments that looked at specific areas, burnout, well-being, depression, suicide risk. And what we're hoping is that we're going to get further feedback from other stakeholders to say, okay, this looks good, but what about this specific area of physician burnout and resilience? So this is a starting list, and we're going to add to it as time goes on.
Thank you, Bob. Art?
Yes.
Okay, so the question is, go ahead.
Go ahead, you can read the question, I think, Charlie.
Yeah, so what is the time frame for releasing the interactive model? It's very useful now, and folks would like to be able to implement it in their work. So if you could talk a bit about our next steps.
So the model, as you see, has now been released and is available for you to look at and use. One of the next steps that will be going on within our group is creating 2 more papers. It looks like they're going to be more in-depth descriptions of these external factors and individual factors, so we dive a little deeper into those and explain them. That will be going on here over the next several months into the spring. As far as the model is concerned, we'll be interested in feedback from all of you on how you view these different factors and the lists we have under those 7 domains to see if you agree with what we have listed there, or whether there's things that we haven't thought of as a group to alter these a little, because as we said, it's dynamic. As far as the model, conceptual model group, you heard how we are working closely with the communication group and how Dr. Ducis talked about what they're doing, because that will be kind of the dynamic development of the next layer. We've been working with the designers and so forth on this, and hopefully as that comes online towards the spring, that can begin to be incorporated into the conceptual model at a deeper level. Thanks, Charlie.
Thank you, Art. And Daisy, will the group address the legal and scope of practice issues that impede team-based documentation?
Yes, so the short answer to that is absolutely. That is one of the things that is on our list. I think I mentioned in my presentation talking about addressing some of the regulatory and reimbursement barriers to documentation and team-based care, but obviously there are legal and licensure issues around scope of practice as well. And not just about team-based documentation, but there are barriers to virtual teams working together. So that's one of the things that is really the power of the collaborative, is that we can take on multiple issues like these with a lot of the stakeholders actually at the table and part of the collaborative. So we will absolutely be addressing this. Thanks for the question.
Thank you, Daisy. And Neil, how does the Action Collaborative plan to include the public in their overall messaging and communications efforts?
Thank you. We understand that the public plays an integral role in this work. As you saw in the conceptual model, the patient is really at the center of everything that we do. We completed message testing this past fall, as I mentioned, and we included patients as part of this work because we wanted to understand how best to reach the public audience. And there's a balance between wanting to inform the public, but also not wanting to scare them, because remember, this is about their caregivers. We found that patients are very receptive and want to know more. One of the goals of the collaborative is to improve baseline understanding of clinician burnout. We will include the public audience in this messaging, and we're going to frame it as a patient safety issue, with patients as the common thread throughout all of our messaging work. The actual text of the messaging is being developed, but the key thoughts are that burnout is a system issue that leaves providers exhausted and overwhelmed, which may reduce their ability to provide the very best care. We hope to engage the public as partners in this work to help reform the system, because we're all affected. We don't want patients to advocate for clinicians. We want them to partner with us to create systemic change so that clinicians can be well and patient care is optimal. And we've begun involving the public through several different mechanisms. One is the art show, which Charlie mentioned earlier. Second is at our last meeting, we invited patient representatives and had breakout sessions in the working groups with them to better understand how they view these issues from their perspective. And we learned that we needed to emphasize that patients are actually a crucial part of team-based care, and that patients can be partners in their own care, which of course is directly relevant to promoting clinician well-being. So we've invited several patients to become involved in our working groups to make sure we continue to promote and engage that perspective. Thank you.
Great, thank you, Neil. All right, we'll go with our next round of questions. So this question is for Bob. Have you looked at the educational sector to identify common tools and approaches to burnout and well-being, as teachers also experience high rates of stress and turnover? For Art, can you elaborate on how clinician well-being is defined in this model? For Daisy, how are you engaging all of the stakeholders within the external environment that might impact clinician well-being and resilience? And to Neil, once launched, how can the Knowledge Hub actually be used to affect change in the healthcare system to promote clinician well-being? And while you all mill for these questions, I'll address a couple general questions. So one was, how can we suggest committee members for the consensus study? And a formal call for committee member suggestions will be sent to our listservs once the study launches, and instructions for submitting recommendations will be included with that public call. Another question is, how does the Action Collaborative intentionally work with payers, plans, and government to mitigate administrative task burdens. And we have a range of stakeholders that participate in this collaborative, particularly public and private payers, as well as some regulators and policymakers that we engage with this work. So part of it is coming around the table to have a common understanding and make commitments to advance change. So really using the Academy's strength as a neutral convener to have these frank and open discussions and talk about action steps is how we plan to move forward. So Bob, to the question about looking at the educational sector to identify common goals and approaches.
Yeah, well, the short answer is no. I mean, we sort of focused on, healthcare providers, physicians in training, nurses, dentists, pharmacists, but we haven't specifically looked at educators. One of the things that was discussed is, should we expand this to look at, PhD investigators who teach our medical students, et cetera. But to this point, it's been focused on healthcare providers. Now, having said that, I think that some of the instruments that we've used and some of the information that's going to be made available to healthcare providers about these instruments and the annotated bibliography will be applicable to other professions. But as a work group, we have not focused on educators.
Thank you, Bob. And to Art, can you elaborate on how clinician well-being is defined in this model?
So one of the things that we don't have up on slides here today is the list of terms and definitions. And I don't have right before me those terms and definitions to read to you, but within that, well-being will be defined along with about 50 other terms that are seen here within the various factors in the model, or some of the other terms we felt important to define that fall under the whole collaborative. So that's where I can refer you to right now, so I don't define it a little differently than we have in the list of terms. And I think going back to the question that was asked of Bob, whether it's related to faculty, students, nurses, physical therapists, the one thing about this conceptual model that we worked hard to create was that it doesn't matter who it is within the healthcare field, this has some application for them to be able to go to look at and find answers on their well-being and resilience and how they can deal with it. Thanks, Charlie.
Thank you, Art. And I do have our terms and definitions up, so I'll just read briefly how we've defined clinician well-being. It's an integrative concept that characterizes quality of life with respect to an individual's health and work-related environmental, organizational, and psychosocial factors. It is the experience of positive perceptions and the presence of constructive conditions at work and in other areas of life that enables workers to thrive and achieve their full potential. So this definition, as Art was mentioning, is included in our list of terms, and it will be available on our website shortly. So to Daisy, how are we engaging all of the stakeholders within the external environment that might impact clinician well-being and resilience?
Thanks, Charlie. Well, we have a range of diverse perspectives in our working groups, including representatives from professional organizations, government agencies, insurers, malpractice insurers, large healthcare centers, technology, EHR vendor representatives, public and private payers. We also have a number of experts that we've engaged by inviting them to speak at our meetings. So we have had speakers from the military, for instance, who has taken this on at one of our public meetings. And we also had a speaker come in from the American Bar Association. So we invite them also to review our resources and author discussion papers. So we really are trying And I think, as was mentioned before, really also including the patient perspective and making sure that our work reflects that as well. So we really are trying to cast a broad net, which sometimes makes it a little bit challenging to figure out how we can focus and really make an impact. But the perspectives that we're gathering are really broad and diverse.
Great. Thank you, Daisy. And Neil, once launched, how can the Knowledge Hub actually be used to affect change in the healthcare system to promote clinician well-being?
Thank you. So first of all, before you solve a problem, you have to acknowledge that it exists, and you have to define it. So the Knowledge Hub does both of those. And then in terms of solutions, one of the things that we found from message testing is that many, many clinicians who were burned out thought they were alone. And they're not. It's very, very common. And so there's a whole bunch of solutions out there that are segregated from one another because people don't talk about it. They don't share their problems and their solutions. So the idea is that we'll have, in effect, a hub and spoke model. The hub will send information out, but we will also collect best practices, suggestions from organizations that are already doing good work in this area, and our other working groups will help us with evidence-based solutions that work. So for example, say you're the dean of a medical school and you know that your medical students might be experiencing burnout. Where do you go? Well, our hope is that you would first come to our Knowledge Hub, search through it, and find out what similar institutions have tried and what has worked, and then roll out the appropriate program for your particular situation, and others would do the same. So the information will go out, the information will come in, and by learning together, we can work together to solve it. The hub will also, of course, give resources on how to measure burnout, rating various tools, collecting studies, clinical trials, research articles that work, et cetera.
Thank you, Neil. Okay, our next round of questions. The first is for Bob. Are there any free, valid, and reliable survey instruments? The list we include seems to all be proprietary. Question for Art is, can we begin using the conceptual model in our own organizations? Third question goes to Daisy. Regarding the paper on team-based care, can you comment on whether this publication will include information about the role of advanced practice pharmacists in team-based settings? And we could probably broaden that to advanced practice providers in general. And then for Neil, how do we go about identifying and defining best practices in well-being so that educational settings and organizations know what to aim for systematically? Do we know what works? So while you think about those questions, I'll address a general one, which is, can individuals submit commitment statements? So we understand the deep commitment from individuals to improving clinician well-being. However, at this time, we are seeking commitment statements from organizations only. So now I'll turn it over to Bob to talk a bit about any free instruments available.
Yeah, so when these are posted, there will be an indication as to whether or not they're free or proprietary, and we will have free instruments available. The ones we have chosen to this point that we thought were the most reliable and valid, looking at burnout, sense of well-being, depression, suicide risk, I mentioned earlier, but I can go through them again. It's the Human Services Survey for Medical Personnel, Oldenburg Inventory, Mini-Z, Copenhagen Burnout Inventory, Well-Being Index, and then a Patient Health Questionnaire 9. So those really are, we think, the best of the best. But if other organizations have areas that they think need to be assessed with another instrument, we would really love to hear about that, and we will take those suggestions, be happy to sort of vet the instruments. And the overall purpose of of this is we would like, for researchers to be able to use similar instruments that we think are valid and reliable. We think that that will make it easier to compare interventions across various organizations, and try to elevate the quality of the research in this area going forward.
Thank you, Bob. Art, can groups begin to use the conceptual model in their own organizations?
So the answer is yes, and if, Charlie, we could bring up the conceptual model slide, maybe? Yes, right there. So I think that what the work group did was after we developed this, Dr. Nora came up with about 9 different scenarios of different issues that could be visualized, and we could test this to see if it would work in terms of how to use it. So an example would be a student in medical school who starts to become withdrawn and obviously depressed and so forth, that the dean of students, for instance, could go and look at the list of personal factors and health roles and pick out several things that they thought might be applicable to that individual as he met with them or her, then goes over and looks at the organizational factors and the learning and practice environment that they're in, and try and pick out some of the things that they see that would apply to that particular individual and problem. And as we've talked about, as the Knowledge Hub becomes available, you can look to that to find resources. So I think that right now it's gone live, but there's still a lot to add into it yet, which will make it more useful. I think what I would hope is that people would start looking at it, trying those things, as I was just explaining to you, and give us feedback of, yeah, that really works, or we have a problem with this or that, because we do want to make it a very useful tool, and that will help us learn. Thanks, Charlie.
Thank you, Art. So Daisy, in the forthcoming paper on team-based care, will we talk about advanced practice providers in team-based settings?
Thanks, Charlie. So one of the things we wanted to be sensitive about in the team-based care paper is that since we're posing this as a potential solution to the burnout epidemic, or a way of promoting clinician well-being, we wanted to be sensitive to the fact that there are many heterogeneous types of teams out there, and that we didn't want to put a one-size-fits-all solution. We didn't want to be prescriptive about team composition or team member roles. So when we highlighted what are the key attributes of high-functioning teams that we could find in the literature, one of the things was just to make it very clear that people knew exactly what their role was, for instance, and people were practicing at the top of their license. So it's a little bit more general, but certainly we will have examples, a table of specific examples of types of teams, so that the idea is we want to make sure that this is a solution that everybody, even people who are in, individual solo practice, can team up with their office staff, for instance. So we wanted to be able to depict what a range of teams might look like, but not in a prescriptive way.
Thank you, Daisy. And for Neil, how do we go about identifying and defining best practices in well-being so that educational settings and organizations know what to aim for systematically? Do we know what works?
Let's start with the second part first. Do we know what works? It turns out that solutions to burnout and promotion of well-being is being done much more widespread than we think. While there are only a relatively small number of meta-analyses of studies that are out there, there's a whole lot of things being done at the local level that are thought to be continuous quality improvement projects that never get published. We hope that those types of best practices will find their way to the Knowledge Hub if they're not there already, so that we'll have a unique resource set that, for example, is not available on Google Scholar or PubMed. And then when you say, well, you know, how can I find what works? As the other speakers alluded to, just like they say all politics is local, all burnout is local. One of my favorite quotes from a Mayo Wellness Group paper is that you don't leave your organization, you leave your immediate supervisor. So the idea is to teach people methods to focus on the drivers of burnout and the things that inhibit clinician well-being in their own institution. And we certainly have resources that tell you how to do that. The first thing is basically listen. Listen to the people in your work unit, identify the factors, and then identify those that you can change in your work unit. For example, you and your work unit can't change federal law, although you can advocate for it, but you can change other things, and start the ball rolling that way. So we're going to have resources about processes, about things that have worked in other places, case studies, and we hope, as I mentioned earlier, to get some things that have not been published in the formal peer-reviewed literature, because they may actually be most helpful for our users.
Thank you, Neil. We are at the end of our time together. On behalf of the National Academy of Medicine, I would like to thank my co-presenters, Bob, Art, Daisy, and Neil, and thank all of you for joining us this afternoon. We appreciate the tireless work you do to improve the well-being of healthcare professionals and look forward to continuing our collaboration. For any questions, please be in touch via email, and have a great rest of your day.
Thank you.
Thank you.